Marilyn, welcome to the forum meeting. If you could turn on your video, that'd be great. There you are. Marilyn Bartlett. I mean, I have, if I was Oprah, these are my most favorite people. You know, I don't have favorite things, but I have favorite people. And Chris and Marilyn and really Dave and Bob, all of these folks are amongst my favorite people in the whole world. So Marilyn, thank you so much for joining us. Marilyn Bartlett, many of you know, she is just a trailblazer in this space of price transparency, negotiating payments as a percent of Medicare. And she's had numerous different roles. She was and Marilyn, correct me if I'm misspeaking here, but you were the director of personnel in Montana, and you were able to negotiate with all of the hospitals in Montana as a percent of Medicare. I know that wasn't easy. I put it out there in one sentence, and there are articles written about you on your great feat, but really to negotiate prices, inpatient, outpatient prices as a percent of Medicare. Some of the largest health systems there I know were reticent, but they eventually did come along, and you were the first to do that. So congratulations. You've also done a lot of work uncovering on the pharmacy side. You've testified numerous times at the federal level. And now you're at NASHP, so the National Academy of State Health Policy, and have been the champion in developing a new tool on hospital costs. So these aren't hospital prices. These are actually what the hospitals, what their costs are to provide services. So thank you so much for joining us today. I really appreciate it. And I'll turn it over to you.
Thank you, Gloria. And thank you so much for inviting me to participate. I just love all the work you're doing and really enjoyed the first part of this presentation. This is excellent. Well, I'm glad to be here today. I am with the National Academy of State Health Policy. Next slide, please. The National Academy of State Health Policy has support from the Arnold Ventures. And through that, we have developed, NASHP, we have developed this hospital cost tool. And as you've heard from the two previous presenters, we haven't really looked that much at hospital costs. We've looked at the prices they charge and compared prices, but what about the costs? So we decided to delve in and look at that, and we developed this tool to help purchasers and regulators better understand the hospital's costs. Now, this tool can be used as a complement to the findings that you just saw from Gloria and Chris from the RAND filings. Now, we are working with several state officials, state governments, and they have expressed interest and have reviewed the tool, and we've worked together with them to pursue a more robust insurance rate review. We just spoke with NAIC with Chris on Monday, including the results in analysis of hospitals mergers. We're working with one state in particular on that, who used the results from the tool. Further informing hospitals that our hospital global budgeting parameters that some states are working on. For one state, we've done an analysis of the hospital community benefit and charity care costs, comparing what we find are the true costs to what is reported in the 990. And then also negotiating with hospital reimbursement as a reference to Medicare rates, similar to what was done when I was at the plan in Montana. Next slide. So what we did was we used the Medicare cost reports because they are the only national public source of hospital costs. There are rules to follow when completing these reports, and every hospital that receives reimbursement through Medicare must complete this report. And it is hospital level data. So it is the data to provide the services of a hospital patient, inpatient or outpatient. And our tool and instructions and narrative are available at the NASHP site, which is provided here. Now, anybody can fill out the tool. It's an Excel workbook. It's clearly identified where you find the piece of data that you need to get a Medicare cost report for a hospital. And it will tell you the worksheet, the column, the line number, and exactly what little element of data to put in, and then it will do the calculations for you. Now, what we're finding with employee health plans is that this is information that hasn't been available to healthcare purchasers before, to really kind of look at the cost, to start the dialogue with hospitals or with your insurance company, your TPA, to really start this dialogue to dig into what the costs are. We do comparisons to RAM 3.0, and then we do not have hospital quality or efficiency measures in the tool at this time. This is focused totally on price. Now, Gloria brings up, and Chris brought up, some very good resources for adding quality into, and NASHP right now is working with different stakeholders on that front. Now, we've been working with collaboration with Rice University. Thank you to Chris, your co-partner, Gloria, down in Houston. We've been able to work with RAND, or with Rice, and they've been able to link our hospital cost tool to the HCRIS database, which is the CMS database that includes all the data elements from all the Medicare cost reports from all hospitals. So we are going to be able to do national, state, regional, hospital type comparisons and benchmarking to kind of help with that data. Plus, it becomes much more readily available to states to work with. Next slide. So I'm not going to bore you. I mean, this is an accountant project, but we've got data entry on the workbook, and I just want to show you this. If you were to use the workbook, you would see some cells shaded in green, and those are the cells that need data entry. And you'll see just to the right, it will tell you the worksheet column line number, so you can just input the cells there. So you'd be using the Medicare cost report and entering the data. So I just want to give you a snapshot, because really you would all go to sleep if I showed you the whole tool. Next slide, please. So we took a look at 3 not-for-profit hospitals in Indianapolis. We looked at IU Health, St. Vincent Hospital, and St. Francis. And you can tell by the bed size that there's quite a variation there. Once we're able to do benchmarking, we could compare regional and national by bed size, and that might help us put this data together. But we used 2018 Medicare cost reports so that we could compare to the RAM 2018 survey, or study, excuse me. And we show in the blue line what the net income is overall for the hospital. And then the fund balance is what is retained by the hospital and builds up over time for net income or any equity infusions from their from their parent company or other subsidiaries. You'll see IU Health has at that time had 4.5 billion in reserves, and the other hospitals were smaller. Now, it's interesting, when hospitals are in systems, you can follow the reserve fluctuations through different Medicare cost reports or their audited financial statements, because sometimes equity goes to home offices and back. But this is an overall snapshot. Next slide, please. Now, we've talked a little bit about physician costs, and I think Gloria and Chris gave a great overview of that. These are Medicare on the cost report buckets physician costs as direct patient services. Now, that's similar to what Gloria defined as a knee replacement. When you have a knee replacement, you'll have a hospital bill, but you'll have a physician bill, which is paid separately. And those revenue channels are not in the Medicare cost report per hospital. We're just looking at hospital costs. So these are costs that the hospital reported that were disallowed. What was disallowed was professional direct patient services, because those are reimbursed through other channels. And those are the lower payments that Gloria and Chris both referenced. The other thing are physician private offices. Those are carved out too, because the theory behind that is that the fee paid to the provider, the physician, will include the physician's overhead as well as the physician's cost itself. But this is a good discussion point, because as you'll hear later in Colorado experience, as we've worked with hospitals, they argue that they lose money on physicians. And so the hospital reimbursements have to be increased to be able to cover these losses. So this is a good discussion point. Now, Medicare does allow hospital physician costs, and those are the doctor costs that are for general patient care, such as hospitalists, emergency room that aren't billed separately. They do allow that within the hospital functioning, but they do carve out these two areas. Next slide, please. So we, looking at taking that other slide forward, we wanted to expand a little bit on what was the hospital profit. So the blue line, we saw this earlier on, the blue line shows the hospital overall profit in the year 2018. But if we were to carve out and not take an expense for those physician costs that are reimbursed through other channels, this is what the hospital profit would have been. So the yellow bar shows the hospital profit excluding physician direct services and private office costs, to give you a picture of that impact. Next slide, please. Now, it's always important to look at payer mix. And I really was pleased to see Rand dig in and show that slide. And we are using that a lot at NASHP because we hear from state governments, and we hear hospitals talk to state governments about how we have to charge the commercial so much because you're not paying enough at Medicare and Medicaid. So we wanted to dig into that payer mix. Now at Indiana, let's take a look at the blue bars first. The light blue will show you the Medicare payer mix, and the blue bar next to it, the darker blue, shows you profit or loss. So Indiana University, their payer mix is about 22%. 22% of their payer mix is Medicare, and on that they were making 6% profit. St. Vincent's in the middle, they have a little bit more Medicare payer mix, and they were making about a 6% profit. We get over to St. Francis, and they have the highest payer mix of Medicare. They're a little over 30%, and they are losing about 8% on Medicare. So that brings up the question, why? Now let's look at the yellow bar. This is what state regulators are looking at too. The light yellow will show you the payer mix of Medicaid. And then the darker gold bar will show you the profit or loss. Now, within Indiana, I have not delved much into your payments when you did Medicaid expansion. I believe that you did a hospital fee. And in some states, that hospital tax then is matched with federal funds and goes back to the hospitals. But it's a little bit different in Indiana. So I think Gloria can help us out with that. But you'll see that Medicaid does lose money in these three hospitals. But if we look at the biggest in St. Vincent's, they have 20% of Medicaid and they're losing 40% on it, but they're just losing 40% on that 20%. Finally, we go to commercial, and the light green bar will show you the payer mix and will show you the profit. And this runs in line with what we were seeing from Rand, and what Gloria showed you in the previous slide is the large profit that is coming off of the commercial. So you want to compare that payer mix, but you want to go back to also what Chris showed us, a very, very good point of that is the reason that we have high commercial prices, is the reason that the hospitals receiving low government payments, and that study showed it's not. Now, one thing I do want to point out on commercial is our commercial, that light blue bar, or green, can't tell my colors, the light green bar is commercial in a bucket. So that's going to include commercial insurance, employer self-funded plans, Medicare Advantage plans. It's going to show TRICARE, federal government employee, VA, all of that in one bucket. And we've been talking about, is there a way to carve that commercial bucket into different payer mix? And we'll be looking at that too. Next slide, please. Now this slide, this one I think is really important. This is the cost to charge ratio. So what this is if you looked at 100% of the hospital's charges, their charge master, you'll see that relatively 20% of that is costs. So what I'm saying is that the charge master is controlled by the hospital. It's private. You can't see that document, and it's subject to change at any time the hospital changes it. And the typical pricing methodology in the market offered by your carriers and your TPA networks is going to be a discount off of that red line. So my point is, if you get a 50% discount, that would be wonderful, you'd think. But you would bring that line down and you'd be paying 50%, knowing the costs are still coming in at 20%. So I really want employers to think about that when you're working with your insurance department, you know, or with your insurance carrier. Just a story from Montana. When I took over the state employee plan, I was looking through the audit reports. Now, this was a blended cost to charge ratio in the audit reports, but it showed that the plan was receiving a 27% discount. But my Medicare cost reports on the hospitals were all showing around 20%. And so that was part of my leverage to try to get those costs down. Next slide, please. Now the hospital cost tool looks at hospital break even. Now that's not what we're saying you'd pay the hospital, because you need conversations with the hospital on profit margins and what are some other things they're doing that are separate from patient care. But we do 4 levels, and not to confuse you too much, but level 1 will tell you what a commercial payer would have to pay their own patient costs, plus any balance from government programs, charity care, uninsured. So that's level 1. What would you want to pay as a commercial payer to cover those? Level 2 is more of a true up. Because of the way costs are allocated between inpatient and outpatient and grouped, we need to do a true up to make sure all Medicare allowed costs are allocated. The third level is, okay, hospitals, you tell us that Medicare disallows a lot of costs that really should be included. So level 3 says, okay, we'll cover those. Commercial will cover all of those costs that I've talked about, and we'll bring in disallowed. But remember, on disallowed, we're not going to bring back in the physician costs or the physician private offices, because we feel those are paid through other channels. And then finally, level 4 is the global picture. We will bring in any of your other income and other expense. And that's usually non-operating items such as investment income, rental income, different items that actually pertain to some of those disallowed costs. So since we're bringing those disallowed costs in of maybe some of your home office costs, then we want the reimbursements back too. And for the for-profit hospitals, it will bring the tax expense in. So these are just points where revenue equals expense. Again, we're not saying that's what you pay the hospital, but it's a good starting point to go to the next question of what should commercial payers cover? And finally, a good place to start for negotiations. Next slide, please. So we took a look at these 3 hospitals in the different levels. So let's look at the blue bar. This is what this is for inpatient, outpatient blended. This is what the commercial payers would pay, the blue bar, to cover their own expenses plus any charity care uncompensated. That's what you'd pay. It's running between 100 and 135% of Medicare. Then we go to the green bar, and you can see there's usually just a little change. That's our true up. That is our true up to say, let's get all Medicare allowed costs in. And it bumps it up to maybe around 120 up to 140% of the hospitals. Now we get to level 3. We're going to cover your disallowed costs. Well, the big outlier there is IU Health in the gray bar. And what that happened to be was actually a little over $1 billion in home office costs that Medicare had disallowed. So we said, we'll cover those. Even if we covered all of those, we're up to a little over 250%. The other bars, you'll see a little less variance. Finally, we go to level 4, which is everything. We're going to cover uncompensated care, any balance of government programs, true up Medicare allowed costs, pay for disallowed, and except for the physician, and your other income, other expense. So the gold bar is fully loaded. Now you'll see IU Health drops quite a bit, because in that bucket were reimbursements for those costs. So when we brought those disallowed costs in, it's really only fair to go to the next level where you can see other non-operating income, and they brought in reimbursement for some of those home office costs. So this is kind of the different Medicare reference points. So now let's take a look at when we compare that to what RAND said. Next slide, please. The orange bar will show you what RAND 3.0 showed you as just the hospital costs. It doesn't include physician. This is what is being paid now compared to those break-even levels. Now, when we have talked to hospitals, we have started off with kind of looking at this break-even analysis and acknowledging this is break-even, and we know there needs to be a profit on it. But then what other services are you performing outside of the hospital care that you want to be reimbursed for? And some of the things that we're hearing from states as well as hospitals is, in one particular area, one system said, well, we have a burn unit in one place, in one of our hospitals that's not making money, so we need the other hospitals to subsidize that. Another one said, we have a lot of clinics and dialysis centers in other locations that are losing money, and we need to increase our prices for that. What we hear quite a bit is we're losing money on our physician practices, and we need to recover those through increasing our hospital rates. So this is meant to start that dialogue, and it's meant to give information to the purchasers, which in my mind are you, the employers, the employee, the taxpayer. We purchase the service. To me, the TPA, the insurance carrier, they're a middleman. They're taking that money and sending it over and managing it differently. But the true payers are the employer, employees, the taxpayers, and the citizens. So this is meant to give you another tool to add to your toolbox of what are the costs. Next slide, please. So NASHP is working with stakeholders, as I said, on quality and efficiency measures, and there's a great team at NASHP that have a lot more experience in that realm that we're working together on. Employer forums, as Gloria showed you, and purchasing coalitions are working on bringing all these tools together, the hospital cost tool, the RAND study, quality metrics, and then with Rice University, as I mentioned, our database is going to give us opportunities to do a little bit more comparison. Next slide, please. Well, I thank you. Again, this is our website for NASHP. You can get the information you need there, or send an email to us, or through Gloria, because Gloria has access to this tool. And Dave, bless his heart, he's been so patient. He has filled out these tools and has helped me flush it through too. And I really thank Dave for his help. Thank you.